Good afternoon, everyone. iTech welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is Differentiated Service Delivery Models, the DSDM, and speaker is Dr. Anwar Parvez Sayed. Dr. Anwar is a public health specialist and HIV-TB physician and is a fellow in HIV. Presently, he is serving iTech India as Director Clinical Programs, where he is working in close coordination with NACO in providing national and regional level technical assistance for strengthening the capacities of centers of excellences in HIV care across the country and assisting HIV treatment program. He is a national level trainer for NACO and has been involved with NACO training since 2011. He is also a member of various guidelines writing groups of NACO. His major areas of interest include training, capacity building, curriculum development, HIV/AIDS and tuberculosis program management, and public health intervention programs. We welcome you, sir, for today's NDLS session. I would request Dr. Anwar now to kindly take over the session.
Thank you, Divya, and good afternoon, everyone. Warm greetings from Aizawl. So I'm doing this session from Mizoram State AIDS Control Society. So I'm very thankful to the PD here and the JD whose room I'm using for this NDLS. So let's talk about this topic, differentiated service delivery models. Many of you might have heard this term for the first time, and there may be many of you who are already implementing some of the models at your ERT centers. So I think this is very appropriate time to have this session in NDLS and also to discuss about these kinds of interventions or models, because moving forward into the national program and also moving forward into the treatment of this disease, I think these models or differentiated service delivery will play a very important role. Before I go into the session, there is a disclaimer that this session is intended to explain the concept of differentiated service delivery models to the healthcare professionals and the program managers of ART and CST. Implementation of any new model at any ERT center shall be done only after consultation and approval of the respective state AIDS Control Society and/or NACO. So before going ahead and before discussing the DSDM model and the concept itself, let's see where we are as of now and where the program is. India launched the ERT program in the month of April, that is 1st April 2004, and since then till now there are 537 ERT centers in the country, and there are more than 1100 link ERT centers across the country. So at these ART centers we have free diagnostic and treatment services to all PLHIV, and over 12 lakhs people are alive and on ART as of now. They are taking ART every month through these ART centers and link ART centers. There are close to like more than 40,000 patients who are on second line and third line ART, and worldwide, if you see, India is has the second largest ART program after South Africa, and if you look at the numbers also, there has been 54% reduction in AIDS related deaths since 2007, and we also have the concept of care and support centers which support the ART centers in outreach and many other social schemes and other things. So we are doing pretty good in terms of the overall achievement of the ART program. If you see, since 2004 till now, there are all these facilities, more than 500 ART centers which are located in medical college and district hospitals. In some states we have ART centers at sub-district hospitals also, and there are these link ART and ART plus centers. So we have the SASEP, which is State AIDS Clinical Expert Panel, established at 98 sites. It's more than 100 now, and it is in the centers of excellence and ART plus centers. So overall, if you see in terms of numbers of people who are on ART and also in terms of facility, the who give these ART medications to all these clients, we are doing pretty good, and this is great achievement by the national program over a period of time. But is that enough? In terms of total number of ART centers and the number of PLHIV who are on ART, as I said, these are at present, this number is of October 2017, but as of now in June month, if you see, we have more than 12 lakhs patients who are on ART. But is this sufficient? Are we doing like what we were supposed to do? And overall, if you see in terms of target, because we have an estimated population of 20 lakhs HIV positives in this country, and if there are 12 lakhs HIV, and the simple maths will be, if there are 12 lakhs people on ART, still there is like close to 40% patients who are still not on ART. So how should we plan for this remaining group to bring them on ART? So what are the 90-90-90 targets? Many of you might be familiar with this 90-90-90 UNAIDS targets. So which explains that like 90% of the PLHIV in the country should know their status, and those who know their status, 90% of them should be on treatment, and those who are on treatment, 90% of them should be virally suppressed. And if we look at these targets through our HIV estimates, so as I said, we have 2.1 million, that is 20 lakhs, over 20 lakhs HIV positive estimated population in this country, and 90% of that, if you want to know all 90% of them, if they know their HIV status, it will be 1.9, that is 19 lakhs, and second 90 will be 17 lakhs, and third 90, which is viral suppression, will be 15 lakhs. So now this is what it should be like in terms of targets. But if you see what it is now, or where we are, if this is the estimated population of HIV positives, we are here at present in terms of diagnosis. There is still 24% gap in the target based on this data of August 2017. That means these many patients have not yet been diagnosed or don't know their HIV status, and they are there in the community on the they are out there, and of those who are diagnosed, we have 1.1 million, that is on 1.2, or almost like more than 12 lakhs HIV positives who are on ART out of this. And that comes to that we have still those from those who have diagnosed, we have 30% gap of ART initiation, but if we add that remaining of the estimated population, this gap will be again further increase up to 40 to 45%. And in terms of viral load scale up, it is in progress, it is still happening, it is new for all of us. So we exactly don't know what is happening in this area. So what is national program doing for this major problem? I think I have spent some time to first of all clarify or mention the problem statement. So what the problem we are facing now is we are having a huge chunk of patients who are still not on ART, and also we are having on the other side, after the rollout of new policies like treat all, we have more and more patients who are going on ART. So case load in ART center is increasing day by day. So what new things have happened in the recent past? Treat all policy was rolled out in the last year. HIV bill was ratified by Parliament. Mission Sampark, which is focused for LFU tracking and also in pre-ART and ART LFU tracking, and that was rolled out. And then viral load scale up or viral load monitoring, which was earlier targeted viral load monitoring, now it is a routine viral load monitoring, and the differentiated care models about which we will be discussing in details. And then integration of other departments, such as revision of the guidelines, that is testing guidelines have been revised, treatment guidelines will be revised soon, and 90-90 targets were adopted. So all these newer initiatives were taken by NACO in the recent past. So and the most significant of that, if you see, of course others are also significant, but this one was actually a stepping stone towards, like, if you want to put everyone on ART, this has been a major landmark. So treat all policy, which was rolled out in the our minister announced this policy at the end of April, and on the 5th May NACO released an OM that every HIV positive will be eligible for ART regardless of their CD4 count, WHO clinical staging, any age group, or any specific population groups. So everyone is eligible for ART. But after this policy was rolled out, what is the impact at the ART center? Let's look at this policy rollout from the ART center's perspective and also from the patient's perspective. So what has happened is now patients who were earlier not eligible because of the previous guidelines suddenly like they all became eligible for ART. So every SACS took this policy with their convenience, and within very soon everyone rolled out this policy in all PLHIVs. But on the other side, at the ART center, if you see, there was sudden increase in number of patients because of increased number of new initiations, because of many mission sampark and other activities, so LFU tracking which was happening. So after this policy change, from both the sides, if you see the health system, which is for us, it is like ART center, if we take an example of the facility based ART dispensation which is happening in our setup, so that got stressed up. And from the other side, from the beneficiary side, if you see, there was a lot of work which was done even on the PLHIV, so that all of them get aware of this new policy and they come to ART center for the initiations. So with this background in mind, one thing is for sure that since long time, that is since the beginning of the program in 2004, almost now 14 years are over, and we are doing one thing in the same way, which is happening, that we are open for ART for every group, every patient, every category of people, and for all of them we have one unique way of managing them. We are doing pre-ART registration, we are doing the baseline investigations, we are starting them on ART, and we are giving them monthly dispensations. So and all whatever has happened till now, it has been a great achievement, but is that enough? So that is a bigger question to be answered. Is that enough to achieve the last mile? Is that enough to achieve that 90-90-90 target? So the answer may be like maybe not. So we need to do some things differently in our existing system, so that all the specific needs of specific people, they are met. And that is what differentiation is all about. So what is differentiated care? If you look at the definition of differentiated care, it is defined as a client-centric approach that simplifies and adapts HIV services in the way that both serve the need of PLHIV better and also reduce the unnecessary burden on the health system. And this is what we were talking about, that on one side there are PLHIV whose needs are not, we are not able to meet their needs, and on the other side, from the ART center side, the burden at ART center is unnecessarily increasing. We'll see what are the further down, we'll try to dissect what are the reasons for that. So this differentiated care is an attempt to maintain a public health approach while acknowledging that patients or people's need change over the period of time. So as I said, we are like almost 15 years in the program now, so there has to be some change in the way we function. So current models for providing HIV services for prevention, testing, care and treatment are stretched to a limit, including ART centers. So if you want to reach this 90-90-90 target, differentiated approaches are needed to meet the diverse needs and expectation of all PLHIV. So we cannot just think of one group or general population. We'll have to think of all groups, all special groups also, and how we divide or how we differentiate, how we make these groups, that we will see in the future slides. Differentiated care enhances the quality of client experience. It puts the client at the center of service delivery. So we are not just saying that we are offering ART to you. We are also saying that, okay, now the patient or client is at the center, and around that we will try to formulate our strategies. So this is a very good opportunity to have a specific intervention in a public health setup. So we ensure that the health system functions in both medically accountable and efficient manner with the existing resources. So differentiated care includes models of care appropriate or suited to testing people unaware of their HIV status, to viral suppression of HIV clients enrolled in care. That means it is across the cascade. Though we are talking about, or we are especially interested in talking about the differentiated care of ART service delivery or at ART center or outside ART center, but all this differentiated care can be done across the cascade from the diagnosis till viral suppression of PLHIV clients. So what is differentiated ART delivery? Till now we talked about what is differentiated care. As I said, it is across the cascade. So it is nothing but differentiated ART delivery is a component of differentiated care. If you see from prevention, from diagnosis to treatment to viral suppression, all this we can do differentiated care at each and every part of it. But differentiated ART delivery will have direct impact on the ART treatment initiations, retentions and all that, and also on virological suppression. So it aims to improve retention and viral suppression by optimizing models of drug and care delivery. It also focuses specifically on clients who are on treatment. So what are different models of differentiated ART deliveries? Like there are basically 4 categories, or in the other words, if I say how can we give ART to PLHIV or what can be the way in which we can give ART, how different it can be. So there are basically 4 categories in which we can divide it. So one is facility based individual models. That means ART refills visits are separated from clinical consultations. When clients have an ART refill visit, they bypass any clinical staff or doctor or adherence support and proceed directly to receive the medications. First of all, I think we need to understand these 2 things, clinical consultation and ART refill visits. See, if you look at your own ART center data or the people who are visiting your own ART center, you will agree with me that many of them, a large proportion of these patients are not coming to the center because they have some clinical problem. Most of them, almost 80% you can say, are just coming to the ERT center for refills. So we need to divide these 2 visits, like we need to look at that who is coming for the clinical consultation and who is coming for ART refill visits. So in this facility based models, under this category the model can be like ART refill visits we can separate from clinical consultation to those who have come for ART refill visits. And so that those who have come only for pill collection, they will not be meeting the clinical staff or the adherence support staff, and they will directly receive the medications and go off. So this comes under facility based individual models. The other category is out of facility individual models, that is ART refills. And in some cases, clinical consultations are provided to the individuals outside the healthcare facilities. That means outside the ERT center or outside the hospital. So that is out of facility individual models. Then the third category is healthcare worker managed groups. That is, clients receive their ART refills in a group, and either a professional or a lay healthcare member manages this group. The group meet within and or outside the healthcare facilities. So there are different groups which can be formed, and which can be the refill can happen once or together in a group form. So healthcare worker manages all these groups, so they need not come to the ERT center to get their refills. And then fourth category of this model can be client managed groups. That is, client receive their ART refills in a group, but this group is managed and run by the clients themselves. So here no healthcare professional is involved. Generally, client managed groups meet outside the healthcare facilities. So, but when you see all these models, these are flexible models. So even though we are saying that a person can take ART from a facility or healthcare facility outside a facility, outside the healthcare facility, in a group which is managed by sometimes by the healthcare worker, and in a group which is not managed by healthcare worker but by client themselves. But whenever these models are very flexible to accommodate the clients who may want to require up referral or standard to the standard of care. For example, if someone requires second line ART, they can be always sent to the centers which are having higher capacities. So now, why is this differentiated care important, or what are the benefits in the other terms? It improves life of the clients. It can improve the quality of care and access to the treatment of the PLHIV. it can better reach the undeserved population and addresses issues surrounding stigma and discrimination. So some places you will see that, or it can be self-stigma also. I'm not saying that stigma and discrimination happens at the ART centers or the facilities. There can be some of the cases, but majority it is self-stigma, that if I am a transgender, I may not want to go to the ART center where there are other people who can make fun of me. Or if I am an PWID or drug injector, I may not go to a routine ART center to collect medicines because I feel that they'll like scold me or do something like that. So because of that self stigma, and at some places it is like stigma faced at the workplace or the by the facilities or the other clients, so people are reluctant to go. So differentiated care models, if we focus on these kinds of special groups and provide them ART separately, it will improve their lives. What can be the other benefits? So it will support the treat all. As we mentioned before, we have about 21 lakhs HIV positives estimated population in this country, and only 12 lakhs are HIV positives. So with this increasing caseload because of the treat all, the health facilities, that is ART center, are under extreme pressure due to lack of human resource and also financial resources. So what we have to do is we have to re-examine how ART care is delivered, how we are giving ART to our clients. We need to relook at it. So the other why it is important is because if you want to reach 90-90-90 with the current approach, if there are like these many people who are on ART, the coverage is just over 50%, but rest of those 40% plus patients are still not on ART. So with this current approach, it may not lead us to this middle 90 goal, which is that all those who are HIV positive, who know their status, should go on ART. So clients who are not currently on treatment with the current models, their expectations need to be met, and we need to put them on ART. But what will happen to the health system if we do that? Our caseload, if we achieve the first 90, our caseload is going to get almost doubled. So we have double patients on ART, and with this existing resources and HR constraint and financial constraint, you know what will happen if we don't act smart, or if we don't work differently from what we are doing as of now. It will also improve the health system efficiencies. It is supporting client to initiate ART is critical, but it is not enough. So, but we just don't want to initiate ART and leave those patients. We want to retain them in care, and we want to improve their adherence, because we all know that that will only lead to the viral suppression, which is the ultimate or last 90 which we want to achieve. So differentiated care interventions can be part of improving retention and adherence and achieving the second 90 as such. So now just look at this picture, and I'm sure most of you or many of you have seen this picture before. There are two terms here, that is equality and equity. So it is not always that it is not about everybody getting the same thing. It is about everybody getting what they need in order to improve the quality of their situation. If you look at this picture, if you give the same thing to everyone, it may not help everyone. So, and someone may not need it also. So you need to differentiate. You need to give things to the person who deserve that the most, and who will improve the quality of his or her situation. So equality is distributing or giving one thing to everyone who comes, and equity is to give those who require it the most, so that it improves its situation, and also some may not require it. So it is very important to understand the difference between these two terms, so that will know that how we are going to differentiate our clients based on these things. So how do I know that which models to choose? So till now we discussed about where we are, what are the big questions for us to answer, and what are the increasingly difficult issues which are going on in the ART centers, like we are losing staff, we are having large number of patients, and which are increasing day by day. There are a lot of LFUs, and all those things are happening. So which model is best for my own center? So is that there is one formula which is applicable to all ART centers, all group of population, it may not be true. It will differ from region to region. For example, if we talk about Northeast, you will have an epidemic which is highly again influenced by people who inject drugs. So you need to have a different category of facilities for those patients. And if you look at the other places, the requirements may be different. So what is the best model for us, or for my own site, or for my own facility? So it depends on specific context. So context can be changing from place to place. So based on the requirement or local requirement, that model will be decided. And how and who will decide that model? Which model is to be implemented? So whenever a model is designed for one particular center to address the issues of that particular center or that particular region, then it should be owned by both the clients and healthcare workers. So first of all, we'll have to look at the requirements of both these groups, that is clients, that is HIV positive people, and healthcare workers, mainly ART center staff in our scenario. So differentiated ART delivery should be implemented as a response to specific challenges or barriers faced by clients, and where differentiation may serve improve quality of care, outcomes, and client satisfaction. So why we are doing all this is because we want to make ease for the patients. We want to make ease for the care provider. So we have patients with us, these HIV positives in our ART center. They are at diverse, their needs are diverse. So their care needs are different from one another. All patients do not require same kind of attention or same kind of management who come to our ART center. If you look at a busy ART center, maybe in Andhra Pradesh or Maharashtra or any other bigger metropolitan city or bigger cities, if you see, there are huge number of patients who are coming in to the facility. Like in a day, a center is seeing like more than 300, 400, or sometimes like more than that. So if does all these patients require the same kind of care? So the answer is clearly not, because as I told before also, that we have almost like more than 80% patients coming to the ART center just for pill pickup. So patient who are first of all, the new patients who are coming to the ERT center who do not have any OI, they are well, they don't have any problem. So in them, they need ART to be initiated, adherence and retention support will be provided for them. Then the patient presenting with advanced disease, the new patients who are coming into the center, getting registered, and they are waiting for ART initiation, but they have all these co-infections or comorbid conditions. For example, opportunistic infections or co-infections with TB or Hep B, Hep C and all that. Those need to be managed. Then there is a category which is called as stable patients, and we'll talk about stable patients in detail in the next few slides. So differentiated care within the community or outside the facility, or ARV delivery models. So for the stable patients, quickly we can think of differentiated care, and we will discuss what models we can have for these patients. And the last category can be unstable patients, and adherence who are on ART, but they are not regular on ART. They will require adherence support, they will require retention, some counseling on retention and all that. Then viral load testing, those who are for example, targeted viral load testing, what we are doing, the CD4 is not going well, they are immunological failure, so we are subjecting them to the viral load testing. Those who are failing first line or second line ART, they require the subsequent second line or third line ART. The drug resistance testing we don't do obviously in our settings, but and complicated opportunistic infections, which management of which is not that easy for everyone. So broadly, if you want to divide all our patients based on their needs of care, we can divide them into these four categories. If I revise, the first one is the new patients who are just present to the ART center, they don't have any problem, they just go for the ART initiation. Next one, patients presenting with advanced disease, we manage their diseases and then we initiate them on ART, but they need clinical support. And then there are stable patients who are years together with us, who are on ART, they are doing good, they don't have any problem, but their caseload, the number of such patients is huge. And unstable patients are those who are on ART, but they are not doing well on ART. Now, what services we provide in terms of like in the whole life cycle of the or the patient cycle. So once the new patient comes in, we do the preparedness. So in which we do the baseline investigation, we rule out the opportunistic infection, we do the counseling for preparedness of ART, and we try to we initiate ART in those patients. And once everything is ready and they are prepared for ART initiation, and we monitor that with the number of ART initiations which are happening in ART center, that is 3.2 hour of our MPR, new initiations. And the intensive support phase, that is intensive retention and adherence counseling and follow-up of the patients of the first 6 months to ensure that they don't become LFU. So we know that in the program there are many of the or most of the LFU cases are happening within first 3 months of ART initiation, and this is one period, first 3 to 6 months, all of us should focus a lot so that we decrease our loss to follow-up. Then long-term retention phase, that is we want patients to become stable, and whenever possible we will do differentiated service delivery. And by that, in this situation, the most common thing what we are doing is multi-month dispensation. We don't want, if the person is stable, we don't want that person to come to the ART center every month, so we can give ART to that particular patient for more than 1 month. That is multi-month dispensation. There has been a previous guideline from NACO where we give ART for 2 months at a time, but we are moving ahead of that, so that we will discuss in the future slides. So there are 3 elements. Basically, models of ART delivery should be differentiated according to these 3 elements. First is the clinical characteristics of the client. Second is subpopulation, and third is the context. This means again the same thing, that how will you divide your patients based on what? So based on these elements, you can say that okay, if I have 100 patients, like 60 of them are stable, 10 of them are unstable, 25 or 20 of them have comorbid conditions. If I divide them like this based on clinical characteristic of the client, that is the one of the elements of modes of this differentiation. Then I can also divide them based on the subpopulation. I can divide them with like adults, children, adolescents, pregnant women or breastfeeding women, or key population, which is very important. That key population includes men who have sex with men, female sex workers, and then people who inject drugs. So and also all these special groups who requires special intervention. So based on subpopulation, so this is one of the elements of differentiated ART delivery. So I can divide my whole population who is registered in ART center based on their these categories. So and the individual needs can be addressed based on the models which I propose. And third element of this mode of service ART delivery can be the context. That means I can divide them if they are from the urban geography or rural geography, or they are unstable context. For example, if they are residing in a place which is affected by conflicts, or based on epidemic type. So there are these 3 major elements under which I can differentiate or divide my population at the ART center. So this is a very good picture, which again gives the details of these 3 elements. That is clinical, based on clinical characteristics, subpopulation, and context. Clinical characteristic, you can say people who have comorbidities, who are unstable, who are stable. So under stable also, again further you can have like those who meet this specific WHO definition of stable patient, which I will come back to, and those who meet the other definitions of stable patients. Under unstable patient, you can say those who have high viral load, those who have suppressed viral load. Like that, subpopulation, those who are men, women, adolescent, and key population. And under that, you can further subdivide under MSM, sex workers, or transsexual or transgenders, or people who inject drugs, or PWIDs. And adolescent and children also you can differentiate, and women who are breastfeeding and who are pregnant, that you can differentiate further. In terms of context, like we said, urban, unstable context like conflicts or high migration and others, and epidemics type like generalized or localized epidemic, you can differentiate these groups. So these are the very three basic or important elements based on which ART differentiation can be done. So we can select any of the subgroup and we can have a differentiated model for that particular subgroup, or even at this stage we can have a differentiated model for them. So there is a 5-step approach which is given by the International AIDS Society to differentiated ART delivery, that is assess the ART data, policy and delivery. So if you want to do this differentiation and want to initiate any such model, first of all you should have a good quality data with you. So for example, in the ART center we are using master line list, we are using registers, white card is very important, then IMS is important. So all these are the tools which we are using for to maintain or to monitor all our efforts in the ART center. So but if we don't have a good quality data, you cannot do differentiation. Obviously if I want to say who is stable, who is not stable, but my CD4 count is not updated in the MLL, for example, my viral load is not updated in the MLL, or basic there are basic mistakes like status of the client, which is who is actually lost to follow, but in the MLL it is shown as alive on ART. So things like this should be very clean if you want to make your life easy. So as we are moving towards these kinds of approaches, I think this is high time now that all our basic data sets should be accurate and updated on day-to-day basis. And once that is done, and once that step is done, and believe me, this is one of the most difficult steps as far as the present situation of ART centers is. Most of the centers do not have updated MLL, and sometimes they have like old formats in which they are making data entry. Sometimes the formats are not standardized, they are using multiple formats. So whenever NACO or SACs come up with any such new initiatives, it takes a lot of time to do data entry corrections and all those things. So so we don't get benefit of all these newer initiatives. So this is the time, I think this is a preparatory phase. Just gear up and make the data sets as good as possible. So the first step is assess this ART data and the policies, the guidelines, and the delivery or the present status of ART service delivery. Then the second thing is try to identify the challenges. Second step is define the challenges. So what are the challenges from the provider side, that is ART center side, and what are the challenges from the beneficiary side, that is patient side. Then define the population in which you want to do the differentiation. Like we saw in the previous slide, we'll take those who are key populations, people, those who are ANCs, for example, those who are stable, unstable, and all that. So define in your population in which you want to do differentiated ART delivery. Then build a model of differentiated ART delivery. Then based on that, based on all this information, you need to build a model which will detail out everything, that what is the background, which is the population you are selecting, why you are selecting this population, and how that differentiation will happen, and how different services will be provided. And whenever into the model, it is not that once you decided to go into the model, it will be like that all the time. So you may have to make consider the additional adaptations whenever it comes to that level. So there are few building blocks. So whenever you think of any model, these are the 4 common building blocks or questions which are asked. Always remember that client is in the center. So whatever we are doing, it should benefit the client ultimately, so that it will affect all the rest of the aspects. So first of all, if you look at the ART service delivery, when we are doing that service delivery, or when we are giving that ART to the client, what is the frequency? Are we giving monthly ART to the client, bi-monthly, or once in 2 months, or once in 3 months, or once in 6 months, which is obviously not there in our site? And where we are doing this? So are we giving ART through ART centers, or link ART centers, or any other sites like rural hospitals, or block level hospitals, or primary care hospitals, or private hospitals in PPP model? Or are we giving ART through the community settings, that is TI NGOs or anything like that? Or are we giving ART at home? So again, that is another building block, that is answering where do you want to give ART from. Then third is, what are you trying to give here? We are giving ART, and we are trying to do ART initiation and refill. And then what are the other services we want to give? We are trying to give clinical monitoring, adherence support, laboratory test, OI treatment, and psychological support. And who are these people who will run this model, or who will actually implement this model? These will be physicians, clinical officers, or nurses, pharmacists, or counselors. So all those people who are involved in care. So these are the four main building blocks. We'll just see what is the advantage of each one and how it is delivered. So when is ART delivered? So right now the ART is given once in a month, or twice, or once in 2 months. But we can we reduce the frequency of ART refills, and can the and clinical visits, can it be like once in 2 months, or 3 months, or 6 months? Then extending or adapting service hours. For example, if suppose in your ART center or in your district there is a group of transgenders who want to come on a specific day, because I know that many of the ART center cannot change their working hours. If you have from like 9 to 5 time, you cannot change that time, you cannot extend most of the time. But can you decide a slot in a daytime where all that particular group to which we are targeting can come together and take these medicines? Obviously, if they want to do something like this, and if that increases their retention and adherence, then that is like will be called as adaptation of the service hours. What does WHO say about when is ART delivered? So, or when ART should or can be delivered. So less frequent clinical visits, that is 3 to 6 months, are recommended for people who are stable on ART. So we'll see, as I said, what is stable patient. Less frequent medical pickups, that is 3 to 6 months, are recommended for people who are stable on ART. So one common thing is, those who are stable on ART need not come to the ART center every month for clinical visit or medication pickup. So that is what WHO is recommending. So if we discuss where is ART delivered, so can we decentralize the services closer to their home, which we are already doing in the model of the Link ART Center. But we all know that how successful Link ART Center model is, and what are the problems of or challenges of Link ART centers, and how far to decentralize. Can we give ART at their home? Maybe not. So it all depends on the context. So how far are we going to decentralize this ART service delivery? So what WHO says about it, this decentralization is a way to increase access and improve the retention in care. Initiation of ART in hospitals with maintenance of ART in public health facilities. That is one option. So you can initiate ART in the hospital, and in the other and maintenance, that is the follow-up of the ART, can be done in the peripheral health facilities, for example rural hospitals or PHCs and things like that. Then the second option can be initiation and maintenance of ART in peripheral health facilities. So in the rural hospital or PSCs, if there are enough facilities there, or the capacity there, then these kinds of models of decentralization can be thought of. Then the third, that is initiation of ART at peripheral health facilities with maintenance at community level, and at the community level the refills can happen or not. So this is like various types of different decentralizations or options for decentralizations. And first option, we are already having that in our program, where we are starting ART at ART centers and we are linking them out to the Link ART centers. So then who is providing differentiated, and who can provide differentiated ART delivery? So it is very important to understand the concept of the task shifting. In many of the developed countries, sorry, there is a concept of, again, for example, nurses, they are equipped enough to give prescriptions of ART and other diseases to the patients, and they are called as nurse practitioners. So they reduce the burden from the medical officer, and because if you look at the number of doctors and number of clinicians we have, will be obviously less than number of nurses we have. So the role of each of the cadre is very, very important. But in terms of those who do not require to go to the medical officer, can take their refills from the nurses level. This is just, I'm giving an example, and this is well accepted. This happens in the Western countries and developed countries. In India, it is not happening till now. So, but what is recommendation from the WHO on task shifting or task sharing? So, trained and supervised lay providers can distribute ART to adult, adolescent, and children living with HIV. So they can anyone can provide, but trained and supervised lay providers, anyone who is trained and supervised, can distribute ART. So they cannot. We are not talking about initiation here. We are talking about distribution of ART, for example. Then trained non-physician clinicians, for example, nurses, for example, midwives or nurses, can initiate first-line ART. Again, we are not talking about complicated cases or starting second-line ART and things like that. We are talking about only initiation of the first-line ART. Then trained non-physician clinicians, again nurses and midwives, can maintain ART. Then trained and supervised community health workers can dispense ART between regular clinical visits to the client. So these are the things which we need to understand, that it is okay that if these people give ART, or especially the refills can be done by these people. Then last is what services we should offer. So WHO package for care of the stable client is that give ART, so less frequent clinical visit, that is 3 monthly or 6 monthly, less frequent medication pickup, that is 3 or 6 monthly, then community based care and cessation of CD4 count monitoring if viral load testing is available. Then but we also, while doing this also, we need to understand that those who are rapidly growing and those who are showing like some OIs or and who require dosage change need to be called more frequently. So they cannot be like called at once in 3 months or 6 months. And when we have viral load available for all the clients, so when do we stop doing CD4 testing? So that is another thing which has come up in the new guidelines. So let's I'll read this quote from one of the PLHIV from Swaziland, but I'm sure that this is applicable, or many of your clients will also be saying things similar to that. What it says is, I do understand why counseling is poor in facilities because the nurses are overwhelmed. So effective counseling is not about numbers. So I'm not a number, I'm a human being. The focus should be on the quality of service I receive. So if we can shift these stable clients, it means there will be enough time for counseling the person who is unwell. So I'm sure that most of you might be listening things like this from your patients also, and you also might appreciate the message what this person wants to give, that if you spend less time on these people who do not require your attention, obviously you will have more time for the people who require your attention. So that is what it says. So if we just see this all elements of differentiated care, there was this subcategory as a stable group. As I said, we can have differentiated model for this stable. Now, who will be called as stable, or who is stable client? So WHO defines stable client. So stable clients are those PLHIV on ART who are adherent and do not require frequent clinical consultation. So that means they don't have any clinical problem, so they don't want to see the doctor or the clinician. So the definition we'll see in the next slide, but it can vary from the group to group, or the based on the again context. So it depends on access to the resources such as routine viral load and monitoring. If it is not available, you cannot have a definition which says that a viral load should be suppressed. So this is the WHO definition of the stable client, that a client should be on ART for at least 1 year. Then no adverse drug reactions that require regular monitoring. The client does not have any current illnesses. She is not pregnant, or she is not currently breastfeeding. Have a good understanding of lifelong adherence and of treatment success, that is 2 consecutive viral load measurements below 1000. WHO also says that if the facility, or in absence of viral load monitoring, rising CD4 cell count or CD4 above 200, an objective measure of adherence can be used to indicate the treatment success. So The NACO define stable patient, which is very similar to the WHO definition, of course, with few differences, like patient should be on ERT for more than 1 year, no adverse drug reactions that require frequent monitoring, no current illness including TB, not pregnant or breastfeeding. Adherence is more than 95%. In the previous slide, if you see, what is it about adherence? Good understanding of lifelong adherence. In our national program, what the way we have defined good adherence is like the person who has more than 95% adherence for at least 6 months. Good understanding of lifelong adherence, then suppress viral load. Until routine viral load is not available, rising CD4 or CD4 more than 350 can be considered. So why 350 is because, as our technical guidelines say, if it is less than 350 CD4, the person will be eligible for cotrimoxazole prophylaxis also, which need to be given once in every month. So now we just saw what is stable. So now who are called as unstable clients, or do unstable client require differentiation, or do they require differentiated care? So in this elements we also saw that we can give differentiated care to unstable clients also. They can have high viral load, or they can be unstable because of the other reasons like OIs or things like that. So a PL-HIV who will be called as at high risk, a PL-HIV newly initiated on ART for less than 1 year but having advanced disease, PL-HIV who is on ART for more than 1 year but is unstable. So these people will be called as people who are at high risk, that those who have advanced disease, for example some OIs or failure and things like that, and those who are having who are unstable based on again the definition we have come to. And here these patients are on ART for less than 1 year, and these patients are on ART for more than 1 year. So advanced, those who have advanced disease, and those who are unstable. So how will we define the unstable patients? So presenting with advanced disease, CD4 less than 200, WHO clinical stage 3 or 4, these can be called as advanced disease. And those who are unstable on ART, for example ART for more than 1 year but they are not suppressed virologically, that means their viral load is still more than 1000, advanced immunosuppression, that is CD4 is very low, adverse drug reaction, then those who have active opportunistic infections, non-adherent to ART, substance use, and mental illness. Then why we should focus on this particular group of unstable patient, or those who are at high risk, because mortality obviously in them is high, because if CD4 is low they are prone for all the opportunistic infections, and if you don't do something for them, they will lose, you will lose those patients. So so unstable patients need to be categorized or need to be identified separately, and we can have differentiated care for unstable patients also. So because of many of these reasons, because of time constraint, I'm not going in all these reasons, but you know that there are programmatic challenges to be addressed if you want to give services or do differentiation, or give differentiated care to the unstable or patients, or those who are having advanced diseases. So what can we do for these type of patients? So what kind of DSDM can be done for these high risk? Now DSDM again, as it stands for differentiated service delivery model. For PL-HIV who are at high risk as I said will involve 2 people, less than 1 year advanced disease, more than 1 year those who are unstable based on the definition. So can we have more frequent visits for those clients, like they can visit weekly or bi-weekly, because they need clinical attention, they need clinical consultation. Now you will say, we have such a patient load, how can we manage this like in a weekly or bi-weekly? Because if you are doing differentiated care for stable patients, then you will get an opportunity to do differentiated care for unstable patients also. You can give more time to those who require the most. You remember that equality and equity equation. Then service intensity, enhanced prophylaxis or enhanced counseling can be given to them. So can we give ART closer to their homes or intermediate care facilities, or like a home-based care? Then special services, can we have this SASEP or NASEP or eSASEP or eNASEP, which is happening these days? Then clinical specialists or medical officer who give these services to them. So there are few examples of DSDM which are happening right now in the ART program, which is obviously one of them which is well known to everyone, that is Link ART Center. Though we were doing this since long time now, maybe 6, 7 or 8 years now, but we were not calling it as DSDM, but actually it is a kind of DSDM model which NACO has adopted way before everyone else might have thought of it. So the other models which are right now functional in the country, there are multi-month dispensation of ART, that is 3 months model. So there are Maharashtra SACs, there are 12 sites where MMD is being rolled out. There are 2 sites in Mumbai which are being rolled out. There are multiple sites in the northeast, especially Nagaland, Mizoram and Manipur, where multiple dispensation or 3-month dispensation of ART is happening. Then co-located ART and OST center, this is a new one, maybe a new one for people. It is called a CAOC. That is, these are the TI NGOs or the targeted intervention NGOs where they have this OST, that is oral substitution therapy for the IDUs, people who inject drugs. So this is harm reduction strategy for them. So they are given OST. So many of the TI NGOs, they are also the OST centers who give OST to these people who inject drugs or PWRDs or IDUs. So what we have done is we are giving ART at the same place to these patients. They need not come to the ART center every month. They just go to the ART center 1 in 6 months. And this model is functional. It was started in Mizoram, Aizawl, but now it has been scaled up to other places like Champhai in Mizoram and other places in Manipur and also in Nagaland. So in Dimapur, Nagaland, we have this COC, and also in Manipur, there are a couple of sites where we have the COC model. Then ART through TIs. Now Maharashtra SACs is again taking a lead in this ART through TI. They are working on a model where ART can be given through TI NGOs, like that is MSM, FSW, and TSTG, and those categories of the key population can take ART from there. And then ART through prison, and this is again one of the unique model which we are still working on. So that might get rolled out in a month or so in the state of Mizoram again. So these are the few examples of some of the models which, based on all that which we discussed till now, are running or functional at this stage, and out of them, I think multi-month dispensation is one model which will be rolled out nationally very soon. So this will be rolled out in few weeks time. So you will receive a communication from NACO regarding this, and also how to do this three-month dispensation of ART. Again, as I said, you will think that okay, now we are giving 1 month, we'll just write 3 months and it will be fine. It is not like that. All that what we discussed till now, identification of the groups, and based on the definitions, we need to differentiate or make groups of all these patients, and then only we'll be able to implement this model. But for that, one crucial thing will be required, which is like data which is clean, clear, updated data which is consistently updated in your centers. So please get it corrected. By the time it is rolled out, you will be ready to roll it out so that you don't face any problem. These are again examples of a couple of news cuttings. So this was actually today's news in the Times of India regarding 3-month dispensation of ART in Mumbai, and this is in Mizo. I can just translate for you. I don't know Mizo, but I have just asked what it means. So yesterday only, because the first model of this CAOC, that is co-located ART and OST center, was rolled out in the 1st December 2017. Now they are scaling it up to 4 new sites for CAOC. So what is our role? Now this is again actually the concluding part of the whole thing. What are ART centers supposed to do for with all this knowledge? So whatever we discussed, what are we supposed to do? What are the action points of the ART centers? First of all, identify the patients who are stable. Like I said, you will require the accurate or the consistent correct data set to identify the stable patients, because if you have suppose 6,000 patients on ART, you cannot search everyone's white card to identify all this. Obviously for some you will have to, but if your data set is strong, your job is only with few clicks you will be able to identify. Then identification of the cause of instability. If someone is not stable, we need to identify why they are not stable, and we need to group them. And then provide need-based intervention. Those who require most care or most attention, they should be given more time and more care and more attention. Then proactive follow-up of all new initiation for 1st to 3 months. As I said before, The data says that most of our LFUs are happening in first 3 months or 6 months of time. So we need to focus on the adherence part and follow-up part, close follow-up in first 3 to 6 months of ART initiation. So that rapport development should happen in these 3 to 6 months. So we need to make all possible efforts to make sure that all patients initiated on ERT should retain in care at 3 and 6 months. And once you do this in the first 6 months time, then after that automatically patients will remain in care, and that is what the data of our national program says. Then multi-month dispensation, and as I said, you will very soon receive a communication from NACO that you can do this multi-month dispensation, but as I said, it has to be done in consultation with SACS and NACO and with following all those guidance documents which will be sent by NACO to you all. So there are few messages from NACO that all clients diagnosed at ICTC should be linked to the ART services or ART centers, and all clients registered at ART centers should be started on ART, because now there is treat all. So we need to see who is not on ART, try to bring them on ART. We need to ensure the preparedness. Like I said, the initial months are very crucial. The person, unless they are like well prepared for ART, if they are not prepared well, we will lose them out after 3 to 6 months. Then explain the side effects to the client. Whatever ART you are initiating, take time to explain them the side effects and other things. Manage OIs well with the resources you have. Then ensure the retention, and we need to look at the retention at 3 months, 6 months and 12 months at least. And once a person is retained in this time points, then the data says that they will be retained for longer duration of time. Then assess adherence properly. It should not be just for namesake, the people doing adherence calculation and writing more than 95% adherence on the white cards, because when we are doing this viral load testing, we are seeing many patients whose adherence was written as more than 95%, but when actually we interacted with those patients, it was actually not more than 95%. So it should be correctly, accurately recorded, and then only you will be able to do all this differentiated service delivery. Do not deny treatment or registration. Any patient HIV positive with ICTC report or even with private report comes to the ART center. Even with private report, then get ICTC done and register, and with ICTC report, register them at any point of time. This problem is happening especially in the bigger cities, where they have divided the locations or regions for the people. So you can talk to the patients, register them, and if you want to send the patient to the other center, you can do the transfer out. So that is always available to you. Aadhaar, it is good to collect that information, but it is not mandatory. So if someone does not have Aadhaar, so it is okay to take the other address proof and register that client. So use transit option. If someone is like visiting some of the cities and they are registered in some other ART center, so in IMS you can use the transit option for giving the ART to those clients. Preparedness is important and not the number of visit. So when we say preparedness counseling, people call patients every month like 4 times because they want to do those 3 settings of preparedness counseling. Number of visit is not important. The preparedness actually is important. So you can take those decisions when the patient will be called as prepared for ART initiation. Explain side effects properly to every client. Differentiate wisely. So make ART centers patient friendly, so that overall, if you see, you can work wisely and smartly. You can reduce your caseload, and then you can pay attention to those who require most of the attention. This is, I think, the last slide. This is the phrase which you may not agree with me. This is just a saying I heard yesterday, that insanity is doing the same thing repeatedly and expecting a different result. So if we want to expect a new result or a different result, I think it is a time to deliver differently. And these are few examples. I think you'll agree with all these examples of mine, and you may have more examples, I think, but so we need to get ready for it. So as I said, any model, if you think of, this is the time that we need to get the basics right. We need to correct our own data, and be honest when you fill in the data formats, IMS and MLL and all that. Keep it updated and keep it up to date for every site, so that we can immediately implement the models once NACO and SACS and they are ready with it, and so that we can have most of our clients can get benefit of it. So last but not the least, I thank the DDG Care Support and Treatment NACO, Dr. R.S. Gupta for his constant support, Dr. Manish and his team for, again, I used some of Manish's slides in this presentation, so I want to acknowledge that. And also I want to thank state AIDS control societies, especially Maharashtra, Mumbai, Nagaland, Manipur and Mizoram, because these are the states which are already implementing these models. So special thanks to Mizoram SACS for giving me this space today to have this session. And also I've used some of the resources from the IAS, and I think International AIDS Society website is a good resource if you want to again know more about differentiated service delivery. I have taken many details from IAS website, so you can just see and you can study so that you can understand the concept better. I have used few slides from again this link also. So already time is over, but I can answer a few questions if you have. There are a couple of questions I'll answer, and then I think we can wrap it up. ART schemes, newly diagnosis about today, should we register that patient? Yes. So newly diagnosed patient, register them first, and then I think you are asking about ART initiation. Should we initiate ART on the same day? Again, it all depends on what has happened. Sometimes it happens. See, patient is tested in private, all investigations are available with the patient. Patient comes back to your site, and now and also it might happen that at some other center, patient and some other facility, for example government hospital only, has undergone all the baseline investigation and everything. Patient is learned and everything is known and fine, and those patients I think you can go ahead and initiate. But more or less generally, if you look at the whole, most of the patients will require some time for preparedness. So you will have to give that time for preparedness. You cannot initiate in ART in those patients on the same day. Then there is another question from Capital Hospital, Bhubaneswar. Please explain transit option again. Transit option is in the IMS. So a person who is suppose visiting some other city and registered in some other ART center which is in different city, and but he is out of medicines now. So that person can go to that particular ART center and use that transit and ART center can dispense the ART to that client by using the transit option. So you need not deny that patient the ART. You can use the transit option and give the ART. I think those were the two questions. Thank you very much for your patient listening and active participation. And please continue.
Thank you, sir, for this informative session. Thanks to all the participants for patient listening. All participants are requested to kindly enter the e-poll, which will be displayed on the screen shortly. Thank you very much.